Thanks, Richard. Good afternoon, everyone. It's great to be with you. I'm Professor of Healthcare Organisation and Management at UCL. I'm also a non-executive director of a combined acute and community trust in London. And I'm also a director of an organisation called COVID-19 Bereaved Families for Justice UK. So next slide. Oh, just to go back, Rich gave me this very easy title. What do we really know about making change, making it stick and at scale? No problem. Next slide, please. So what I'm drawing on is some work we've been engaged with over the last 10 or 15 years, plus a whole load of other research and evidence synthesis. So I'm going to draw on these briefly through the presentation. So one is we've been very fortunate to be able to evaluate major system changes, one of which was the centralisation of acute stroke services across London and Greater Manchester, which you may know about. Similarly, we looked at the centralisation of specialist cancer surgery in those same two regions. During the pandemic, we studied remote home monitoring for COVID-19 patients, also known as virtual wards, national rollout of that. And we're currently looking at the implementation of AI for chest diagnostics, again, nationally. We've also had a research program on the role of boards in quality improvement. So I'm drawing on all of that, and also, as I said, a whole lot of other brilliant research not done by us, and evidence synthesis and so on. A health warning: a lot of this research was carried out in a very different fiscal context, as in there wasn't a lot of money available, but more than there is now. And secondly, and actually as important, maybe more important, is that the context for, as Shane and others have said, in terms of staff morale and knackeredness, was very, we were in a different place then for a lot of this. So bear that in mind. Next slide, please. So again, I stole this from Rich because this is what he told me to talk about. So, what are some of the myths about change? So let's talk about those. Next slide. First one, which Shane has already referred to. So the first myth: structural change is required. In my experience of being in research and healthcare, this is what policy makers reach to rather than actually deal with the difficult issues. So we did work on mergers in the 1990s, which is our most cited research, and it's the one that has had the least impact. It's completely ignored, and mergers are still being talked about now, sadly, and they're a huge distraction. The benefits, such as they are, take many years to come to fruition. I could do a whole presentation on those. So let's not do structural change. Second myth: it's that change is a purely technical endeavour, that you don't need to pay attention to social influences. I'm sure no one thinks that on this call, but there are people who unfortunately focus on the technical endeavour. And a couple of examples of that: it's great work by Pat Putzi and others looking at change and sustainability of change, and that what they say, innovations are assumed to be standardizable, self-contained packages that can be mechanistically transferred across settings. And we come across that time and time again. So with the COVID-19 virtual wards, a number of them had developed during the first wave of COVID across the country on an ad hoc basis, clinicians getting together, my favourite example, over a kitchen table on a Sunday evening, implemented it on the Thursday. NHS England, bless their cock and socks, got onto it in about May, June, and decided, yes, this was right for national rollout to deal with what was forecast to be the second coming wave, and had a national SOP, standard operating procedure, and were then surprised to find when that was not implemented everywhere to the same degree. And again, I know it's very obvious for all of you who are involved in these things, but we do need to keep saying it. Another example: that digital and AI are the magic bullets. Of course they can help, But again, with COVID virtual wards, believe it or not, our first very rapid evaluation that we did in 2 months, we had to say you cannot only have a digital model, you have to have an analog model, that is clinicians phoning patients to see how they are, for those that cannot use digital digital method. And again, can't believe that you have to say that, but you do. I can't remember what number I'm on, but X number, myth that top down, what we call designated leadership, is sufficient. I don't think I even need to talk about that, but just telling people to change won't work. Policy and financial levers, so things like targets and financial incentives, will make change happen on their own. That's another myth, but I'll come back to that. They can be helpful. That you don't need to learn from history and context, and that additional funding isn't required. And I appreciate this is a bit controversial, but time and time again, I think the evidence tells us something else. Next slide, please. So now we go on to that first one. I couldn't find one that said evidence, research evidence, rather than myth, but bear with me. So what do we know in reality from evidence? So first of all, it's really important to build the drivers, the narrative for change, with a wide range of stakeholders. So what's the evidence for the change that you want to make? What evidence are you trying to implement? So with the stroke example, we had 20, 25 years fantastic clinical research that told us what you needed to do to treat stroke patients, and that was not being implemented uniformly across the country. So in London and Manchester, they wanted to reorganize their services so that that clinical evidence could be implemented. What's the theory of change? How is this change that you want to make going to get the outcomes that you want? Who's going to benefit and how? Again, it seems obvious, but a number of people launch into change without answering these questions. Be clear about the purpose. To what problem is this the solution? Again, with restructuring, this question is not addressed. And if it was, perhaps they wouldn't reach for the restructuring lever. So change is a human endeavour. The importance of social influences in both developing the drivers for change, that narrative, and in the implementation, and the need to adapt both the innovation and the change to different contexts, and the way it's implemented, and over time. Next slide, please. So the role of network governance, and just to unpack that a bit, when we looked at the centralisation of specialist cancer surgery, that was implemented by a provider network, which was really interesting because that contradicted my next point. Well, not contradicted it, but kind of added to our knowledge about the next point. So that provider networks can implement substantial change, and we've got further lessons from that study about how they can do that. From the stroke work, what we found was important was the combination of top-down and bottom-up. So the top-down being system-wide leadership and bottom-up clinical leadership. So where the change is led by and really driven by clinicians, as it particularly was in the London stroke system, combined with system-wide leadership that can deal with resistance, which is my next point. So we know that all change, you come up with resistance. So need to think through how you're going to address that. It often requires system-wide authority, not necessarily. With the cancer one, what we found was that if you have well-distributed leadership throughout the network, you can help address resistance that way. But if you really want change, you have to take it on. So in Manchester, in the stroke example, they implemented a less radical model, which was less successful because they went for a consensus model. They wouldn't really deal with the resistance. So it is important to do that. Engagement with all stakeholders, especially patients and the public, in a manner of co-creation, which perhaps we can come back to. It does require robust governance, and I've put this reference at the end. I cannot pronounce this person's name, prize to anyone that can. It's a great look at governance in the time of COVID and co-creation from different organisations. And finally, learning from history, especially non-implementation. So again, with the cancer specialist surgery example, in Manchester, there wasn't enough learning about why things previously hadn't been implemented and how that should be taken on board. Next slide, please. So, performance management, it is important. There are, of course, caveats, but actually setting standards as they did in the London stroke system, which I should say led to decreased mortality and decreases in length of stay and was shown to be cost effective. They did set standards and link those standards with financial support. So if providers met these standards of stroke care, they receive funding to provide the ongoing service. Facilitation support for implementation is really important, and headspace or Slack for those implemented. And that's where my point about it does require funding. I think I'm not saying it's impossible to do change without additional funding. I'm sure it isn't, and you'll give me examples, but it certainly does help. And in this current context, I really think we need to think about that. Digital AI, that should say proceed with care. You know, I'm not saying this can't be helpful, of course, but on it, of course, they can help. But proceed with care, and it's part of, you know, take into account these wider issues about human relationships and how patients interact with these innovations. Evaluation is really important. We need quantitative and qualitative data, formative and summative. So formative, I mean evaluation that can tell you what's going on as you go, and so you can learn, and summative in the end. And I'm lucky to lead one of a number of NIHR-funded rapid evaluation teams who are involved in rapidly evaluating innovations. But my argument would be that NHS and care need to become much more that homegrown expertise around evaluation. And in terms of sustainability, how do you make it stick? You need all of the above. And more adaptation to context, independent evidence. Does it work, your innovation, your change? How and why did it work are just as important, and consistent leadership. Next slide, please. So final thoughts. Rich asked me for 3. Sorry, I've got 4, but I actually quoted from this work by Papuzzi and others, which I think is really important, in addition to all the stuff I said about designated and distributed leadership and so on. But first, develop adaptive capability in your staff so that it can make good judgments with limited data, although I'd say, please, can we get less limited data, and self-organize to adapt interventions for intended aims. Give attention to human relationships so that people can work together to embed improvements with reciprocity and goodwill, which are needed. And I would particularly say, can we work much more closely with service users, patients, families, and the public? I think historically we've been poor. NHS has been poor at that, and we can get much further if we work much more closely with those who use the services. Productively harness conflict. There will be conflict. We can't pretend there won't be, but get the contesting views out there and bring together in a constructive way. And finally, I would say this as a researcher, but build in evaluation from the beginning. Be clear about what data's needed, and that is my last word. I've included just a few resources on the final slide, some of which are kind of short and pithy for those that don't have time. Thank you.